Hi, everyone, and welcome to the Art of Innovation, where we explore groundbreaking approaches to vascular health. I'm Kim McNicholas, joined by our guest co-host, Dr. Michael Misha Ginsburg, who brings his clinical experience performing embolization procedures for hand osteoarthritis, for knees, all of the above. And we're going to be talking a lot about that today. That is today's topic. We're talking about embolization. It's a personal topic for me because in recent years, I've experienced early onset osteoarthritis in my hands, particularly my thumb, which I just found out as we were waiting for this show to begin from Dr. Kadar, that for women over 50, although I'm 2 weeks before I turn 50 at the airing of this show, he guessed it, that more than 30% of women actually have an early onset, or maybe it's not an early onset. It's just an onset of osteoarthritis in their thumb. But my father as well has been struggling with hand osteoarthritis. Like many patients, we've been searching and searching for solutions beyond conventional treatments. And that search led me to discover hand embolization, a fascinating procedure that targets abnormal blood vessels in the arthritic joints. This perfectly aligned with our show's focus on circulation innovations. And today we are honored to welcome Dr. Yuji Okuno from the Okuno Clinic in Japan, the creator of the Okuno Method, the godfather of treating osteoarthritis in the hand through embolization. We're also joined by Dr. Asaf Kadar, an orthopedic surgeon specializing in hand and upper limb conditions, and he is a pioneer of his orthopedic methods as well. So I can't wait to hear about those. Dr. Kadar leads research at the, and I may mess this up, the HULC Bioengineering Lab, developing new suspension plasty hand and digit devices. Can't wait to hear about those as well. And together, all of us are going to explore both interventional and surgical approaches to hand osteoarthritis, giving you a comprehensive look at treatment options beyond the standard medications and numerous steroid injections. Dr. Ginsburg, my amazing co-host, did I do it justice at all?
Perfect. And you know,
oh, good.
What I can say, I would never be able to tell. You're coming close to 50s, but you know.
Thank you.
But
I appreciate that.
What used to be 50s is today 30s, right?
Exactly. 29 forever. I never thought I'd hear myself say that, but yes, I'm now 29 forever. But this osteoarthritis thing, it just reminds you that, nope, you're not 29 forever. Yep, you are going on 50 here. And beyond 50, if those folks are watching this on rerun in September. But we have an amazing, would you mind just introducing us again to our amazing guests that both you and our friend we call Dr. Oz set us up with here?
Sure. So Dr. Okuno, as you mentioned, is a widely recognized innovator behind musculoskeletal embolization, sort of a groundbreaking, minimally invasive approach to arthritis. It targets abnormal blood vessels to alleviate chronic pain.
Yeah.
For conditions like osteoarthritis affecting large joints, like the knee and the shoulder. And now, and more recently, also targeting smaller joints, which is one of the topics we're going to basically focus on today. So, among other things, through research on temporary embolics, as well as applications across different type of joints, he's joining us today. And we are really lucky and fortunate to have him today, straight from Japan. And let's just dive in and how all of this began, Dr. Okuno. So, can you take us back to the early days? What inspired you to explore this whole embolization application in musculoskeletal world?
Yes, thank you very much. So in the beginning of the idea that embolizing the inflammatory nerve cells, it started at 2007 or 2008. And at that time, I was an interventional oncologist. Oncologist means treating cancer treatment using a catheter. So I use a catheter. I was interventional radiologist and using catheter and insert it to the artery and inserted to near the tumor vessels. So tumor cancer tissue requires lots of blood vessels. So they develop the abnormal increased blood vessels. That we call the tumor blood vessels. That is, it's not different from the normal vessels. And during those times, we noticed that inflammatory tissue, chronic inflammatory tissue, also contains lots of abnormal blood vessels, like we call it inflammatory blood vessels. And the first idea is like a cancer treatment, we can reduce the inflammatory intensity by blocking the inflammatory vessels. But as you know, the blood vessels, normal blood vessels, is necessary for the human body. So we cannot stop the blood flow of the normal blood flow. So we invented to infuse a temporary embolic material. Temporary means 1 minute or 2 minutes or 10 minutes or 20 minutes. And it recanalizes in the normal blood vessels. But the ability of recanalization is different between the normal blood vessels and inflammatory blood vessels. So we can selectively reduce the inflammatory vessels by doing the temporary blockade. And we can remain the normal blood flow. So this procedure is totally safe, and so we invented around that, and we did like a basic research using animal model. And after that, 2012, we have started the clinical trial in Japan, Tokyo, and it applied to knee osteoarthritis, or frozen shoulder. And after that, we also applied this to the hand osteoarthritis, like thumb base osteoarthritis or finger joint osteoarthritis.
So this all stemmed, the discovery really was that you were treating cancer and you thought, well, wait a minute, we could actually apply this same theory to osteoarthritis. That's really the moral of the story. That's incredible. And your first cases, were they in the hand or were they in the knee?
First case was shoulder. The
first case was the shoulder.
Yeah, frozen shoulder. The patients who have left mammalian cancer have also developed the frozen shoulder in the left shoulder. So she could not sleep and she could not lay down without pain. And 1 month or 2 months passed from the symptom beginning, and we did the procedure to treat the cancer, and at the same time we have performed angiography, and we know that that is not a metastasis and that is a frozen shoulder. So that is the first case, is the 2000 preliminary one is 2007.
Oh, that's incredible. Well, coming up right here on the Heart of Innovation, we're going to have more with Dr. Okuno. We're going to learn more about hand embolization. We're also going to learn about some new orthopedic methods as well. So stay with us right here on the Heart of Innovation. Don't go away. You don't want to miss a beat.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just step aside?
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should, because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for.
Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Welcome back, and here we are today and we have wonderful guests discussing hand osteoarthritis and new innovative treatment option, musculoskeletal embolization, and specifically hand embolization by one and only the pioneer, and as Kim correctly coined it, the godfather of musculoskeletal embolization, Dr. Okuno. And we're also very lucky and fortunate that Dr. Kadar agreed to join us today. He is a specialist in hand osteoarthritis. He's a hand surgeon, an orthopedic surgeon back from Canada. And he runs a lab that explores new innovative devices as they apply for hand osteoarthritis and base of thumb arthritis. So Asaf, maybe like we had earlier today, you kind of started mentioning the demographics and some of the background of hand osteoarthritis. So if you can just introduce us to the sort of conservative route and conventional route of treating hand osteoarthritis as a hand surgeon, how you get the patients, at what stages, how you sort of address them, and how do you escalate therapy?
Yeah, so hand osteoarthritis at the base of it is a disease of cartilage. Like any osteoarthritis, basically two bones rubbing together, and you have bone-on-bone contact, which is, we think, a pain generator, which causes pain. We have it in the knee, we have it in the hip, and it's very common to see in the thumb, as I mentioned before. Over 30% of postmenopausal women will experience some form of hand osteoarthritis, so it's a very common problem, and it's a problem without a solution. So, and we get these patients at definitely various stage of the disease. So it can be a very mild disease where you won't see anything on X-ray, or it can be a progressive disease. And the treatment is, tailored to the patient. We have a huge variety of treatment options. We just learned about the embolization today. I at least learned about it today. So, when you have so many treatment options, that means that you don't have one good option, as you know. We don't have 500 ways to replace a hip joint because there's one surgery that works. So the thumb is not the case. So as you said, the treatment will be tailored to the patient. So for instance, usually patients in the very early stage will be treated with pain medications or anti-inflammatory drugs as simple as Advil. Next step of that treatment ladder usually would be hand therapy, and the hand therapists are, our colleagues, and they do wonders. There's a lot of innovation in that field as well. It's a huge, huge field. 3D printed braces are a big thing now, and technology is evolving there. So as simple as taking a camera from your phone, scanning your hand, and then the company will sort of like print out your 3D printed brace. And studies have shown some improvement over traditional braces that you buy in, one of the, Walgreens or something like that.
So the whole idea there is just to keep it immobile. So exactly. You probably can't see, but right in here you can see.
I see.
You see, we'll do something. It's not painful though, but with the brace, is it just that, which is good. Sometimes it feels a little stiff, but is it just that it stabilizes it so that you're not continuing to have bone on bone and creating an even bigger bump there and even, pain at some point?
I think the principle is immobilization mostly, and reducing the load between the two bones, which is the base, this bone, the metacarpal bone, and the trapezium, which is where the arthritis happens. If we talk about the next step, injections, we're looking at injections, usually steroid injections into the joint. We can do it with or without imaging. Now I would say I would recommend doing it with imaging for almost everybody because it's more accurate. And then the next step of that ladder will be surgical treatment. And there's certainly a lot of innovation there. I think there's going to be a huge change in the way we treat this problem in America and Canada in the next 2 or 3 years. Things have begun in Europe and have been progressing there for the last 10 years. which is basically replacing that joint. So if you believe it or not, right now we're not replacing that joint, which is arthritic. We're just removing part of it, which works. But I think replacing the joint, is the way of the future here. So that surgery has had very bad reputation in the past, but now new technology really improved the outcomes. So it's going to be a huge shift in the way we treat that problem.
And coming up right here on the Heart of Innovation, we're going to find out who is the perfect candidate for this. Just how bad does the osteoarthritis have to be before a patient actually qualifies for a joint replacement in their thumb? Just as if you were going to get a knee replacement for knee osteoarthritis. And we're going to ask Dr. Okuno whether the hand embolization, the osteoarthritis embolization in the thumb, maybe in particular, may delay these types of surgical procedures. So stay with us right here on the Heart of Innovation. Don't go away.
Your type of condition is called critical limb ischemia. It's the most advanced form of PAD or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to PAD and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with PAD.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options. We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back. And here we have Kim, Dr. Asaf Kadar, and Dr. Yuji Okuno, and myself talking about hand osteoarthritis, a new innovative treatment, both in the world of conventional world of hand osteoarthritis with very exciting developments in the field that are about to happen in the next year or two. And we have Dr. Okuno with Okuno Method, straight from Japan, Tokyo, and who is talking to us about specifically today embolization for hand osteoarthritis. So Dr. Kadar did a great job introducing us to the background and demographics of hand osteoarthritis and how it's treated today. And we were just getting into this conversation about the spectrum of disease and where different treatments come in. And I think this was where kind of Kim sort of said, let's now review who are good candidates for embolization for hand osteoarthritis. What is the evidence up to date to the effectiveness of this technique? And what do you think, and that is a question both for Dr. Okuno as well as Dr. Kadar, would convince Dr. Kadar that this has significant potential where he would potentially refer a patient?
I'm just wondering in terms of the surgical, the replacement of the joint would come way far down. It has to say, it's waking me up at night. I would imagine for you, that would be what you're doing with hand embolization would come first and more early on. Is there, you have the steroid injection, or maybe you have the PT, maybe medication, PT, then steroid injections, then the embolization?
And now we can do more audio. If you more audio, and we recommend to do embolization, and even though the patient who have never received the steroid injection, because as we every physician can agree that steroid corticosteroid is damaging the joint as a cartilage, so we don't want to do that. And if you had that embolization procedure, you must feel that that is a very invasive, and actually it was in the early of my career. We have performed the puncture using a needle to the femoral artery, groin, and insert the catheter, long catheter, to the hand. And that was very long time. It takes a long time, and using an expensive device. But now we have invented the new technique, that is the Okuno method, and we using ultrasound and observing the radial artery, the one of the most famous, and we can use to pump the and we just use a 27 gauge needle, that is very small needle, to directly puncture this point and inject the temporary embolic material to this peripheral area, and we can treat some base and also treat this finger joint at the same time. But the important thing is it takes 1 minute, and the needle size is very small, and it's minimally invasive, and invasion is smaller compared to the direct injection to this by using steroid injection. So we can do that without a severe, without a big invasion, and sorry, this is a minimally invasive treatment, and we can do more earlier compared to the steroid injection. And we believe that, as you know, the inflammation drives the degenerative change. So the early stage of the sun-based inflammation, the patients feels pain and in the daily life, and the stiffness or the symptoms, earlier symptoms, the patients already have the inflammatory vessels, but still the cartilage is remaining. That is a phase, is a good phase to start. If the patients have end-stage osteoarthritis and the cartilage totally lost, and the bone marrow is disruptive, in those cases, we cannot contribute a lot. So our embolization procedure is fit to the early stage and middle stage, moderate stage, but end stage we cannot do. We cannot contribute a lot. That is a basic concept.
Do you have to go in? How invasive is the diagnostic? Can you tell what stage they're in just by an X-ray and or ultrasound?
Yes. We have a grading of Eton grading, that is X-ray grading of the degenerative change, and we also can do the ultrasound diagnosis, and we can see the thickness of synovial tissue, synovial membrane, and we can see the increased color Doppler signal, or that is also useful to diagnose.
Can you do all of the fingers?
Yes, we can do other
in one procedure.
Yeah, one procedure. Sometimes patients have not only thumb base but also the finger, the second finger or fifth finger. So we puncture the radial artery and the ulnar artery, and we can treat the both.
So Kim, it's non-selective, right? Like they basically access radial artery and infuse the temporary embolic, and it affects the entire hand, right? It affects the first metacarpal joint and affects all the other joints, and it's temporary, right? So and it preferentially goes to the inflamed tissues, because those are the more hypervascular tissues. And Dr. Okuno can tell us about the method, how he sort of came up with the embolic, if specifically, and ultimately I'm kind of jumping the gun, but what's the evidence today, where we are today in terms of evidence for hand osteoarthritis? Because I think that's what Dr. Kadar is interested, because he's clearly excited for his patients.
Yeah, so our results showing that for the early stage and the moderate stage, like even grade, like from 1 to 3, the patients have a clinical success rate was around 80 or 85% for the two times injection, like 1 time and 2 time, and 2 years later, the clinical success keep maintain for the 85%. So I think it's a relatively good results, and the most of the patients have already received the corticosteroid injection in that cohort. So I think we can apply this technique in the early stage and also the moderate middle stage.
And coming up right here on the Heart of Innovation, we'll have more with Dr. Okuno and Dr. Kadar. We'll get Dr. Kadar's reaction to hand embolization coming up next right here on the Heart of Innovation. Don't go away.
I remember when I went to train with Marco Manzi for a week, it really opened my eyes as to what can be done in the tibial vessels. And we were doing a case, and he had said, failure's not an option. And I think that's always stuck with me. There's a fine line between pushing the envelope and being too aggressive and putting that patient at risk. But there's also I call it my spidey senses, but there's also that like sixth sense that gets into your head and tells you, I think I can push this, or maybe I shouldn't. And I always tell people, listen to that voice in your head that's saying, go for it or pull back, because it typically is telling you to do the right thing. And that's always stuck with me. Failure's not an option, but listen to the, whatever you want to call it, my spidey sense or my sixth sense.
And I see Dr. Sorasis nodding. You agree too, huh?
I couldn't agree more. I had a similar conversation this morning. I don't think what we do will ever be replaced by AI or whatever you want to call that, because there's that weird sense that you get when you're operating, or even when you're doing a ward round and you're seeing a patient or in clinic, and you kind of know when to stop or why you need to stop. And you can't really explain that very easily. It only comes with experience. And that's why I think trainees need to be in the operating theatre for far longer hours than what they're currently spending in theatre, at least in the UK.
Yeah, it's that really scares me, the limited time that are, well, we have residents and the workout restrictions and the fact that they don't stay overnight, and there's all sorts of stuff. But it's like, and I always say this, it's the Malcolm Gladwell's 10,000 hours. The Beatles just didn't show up in the US and know how to play. They practice hours and hours and hours and hours and hours and hours. And that's what we have to do. And that's what kind of scares me. But yet, Thanos, to your point, you can't explain it. And that's why I agree. You can never replace what we do with a robot, because there's just something. And I don't know what it is, but there's something.
Absolutely. You don't just open up a tibial artery. There's far, far more to it, really. Yeah.
Mm-hmm. Which is cool.
Welcome back. So we just finished this amazing conversation about when to start treating with embolization, and we heard that Dr. Okuno recommends treating patients with hand osteoarthritis at an early or moderate stage. We heard about some of the high clinical success rate, especially for the early stage, and how simple the technique is. How simple, straightforward, requires ultrasound, can be probably performed in someone's office or clinic, and just 27 gauge needle through the radial artery, no selection. What is it, 5 minutes and done, Dr. Okuno?
Yeah, 1 to 2 minutes. Yeah.
1 to 2 minutes and done. Yeah, so mind-blowing, right, Kim? Dr. Kadar.
Wow.
Yep. So
please challenge us.
No,
what would it take to get
first of all, I will definitely want to try and see the evidence. I did have some questions. I would say about 10 years ago, and probably still some places will teach that to the medical students. They said you can't inject anything near the fingers or near any end organs like the nose or the ear, you can't inject adrenaline because the blood vessels will constrict and then will go into necrosis. So how can you, so I'm going to challenge you, how can you justify injecting a material that you know that clogs the blood vessels into the tip of the fingers and maybe, or the area, and maybe ask you if you saw any complications like finger necrosis or something like that with your technique?
Yeah, thank you, Dr. Asaf. So first we heard about embolization of fingertips. So all physicians will feel that such a risk of the fingertip necrosis or other. That is, of course, there is a reasonable concern, but please notice that our agent, temporary embolic agent, is recanalized is very fast. So within 10 minutes or 20 minutes, turn to normal color. So it's totally safe. So in Japan, we have performed more than 5,000 cases per year for the finger osteoarthritis, hand-based and finger osteoarthritis, and no one has developed necrosis or.
Dr. Okuno, 5,000. I'm just making 5,000. You said
5,000 per year. Yeah.
Wow.
Yeah. So it's very safe. We can say that it's very safe, and but still it's effective. There is one paper and published last year that they for doing the animal study that they compare the recanalization process between the normal blood vessels and inflammatory blood vessels, and after doing the temporary blockage and the normal blood vessels decanalize within 90 minutes, almost at 10 to 20 minutes. But the inflammatory vessels gradually decrease in 90 minutes. So that is the difference, and we can use this difference to do the procedure without risk of necrosis.
So you mentioned that you did 5,000 cases in Japan. Did that affect the rates of, let's say, steroid injections or any other treatment? Did you see any shift in the way you treat osteoarthritis of the thumb?
Yeah.
In
so
general,
now
less. Yep.
It's not general, but it's still new. But we have now in Japan we have 150 clinics, orthopedic clinics, who have already introduced this technique because not only the interventional radiologist, but also the physician who can use the ultrasound can also do this technique because this technique is very simple. So we feel that in this area, the gradually changing the treatment algorithm,
the paradigm. Mm-hmm.
Yeah. Don't get me wrong. I'll be happy to stop injecting steroids into the joint. I think it's bad for the joint. Find anything that is very minimally invasive, it's better to use it for sure. Certainly, we were interested in where it will fit into the treatment algorithm. But did you ever compare it to, let's say, if you inject anything else into the?
Yes, that is.
Did you do like a clinical trial in comparing it to saline first, as an example?
Yeah, thanks so much. So that is one kind of evidence we have to now required, and now we are doing the sham control trial, and but we have to choose because we have lots of indications. Now we start with the tendinopathy. Tendinopathy means that like tennis elbow or Achilles tendinopathy. We are now doing that the clinical trial between the sham and the control group. And the other thing is that in US for the knee osteoarthritis, we do the physicians in UCLA who is now doing the randomized control trial between the steroid injection and embolization treatment. That is, yeah. But I totally agree that we need to do that the comparative study. That is the most important. And I think the two things is very important to change the paradigm. Because most physicians now doing the steroid injection, but the important things, one is a safety profile, invasive, minimally invasive, 27 gauge needle, and very safe, no complication for the 5,000 per year. That is important. The other thing is the price of the medical device. We injecting the very cheap, using a small needle, a small syringe, and embolic material is now using imipenem. Imipenem is very cheap, so we can use a $1 or $2. Is a very cheap. That is also important things to become the primary treatment option. We want to change the paradigm or treatment algorithm after the conservative treatment.
And I'm curious in terms of PRP stem cells, that's what I ended up having so far, actually in both hands, that helped to alleviate. So now I don't have, I have full mobility back and I don't have any pain. I have the inflammation in there. I don't know if that'll ever go away, but at least right now I don't have any pain. It's just unsightly. What do you think about PRP and stem cells as, compared to this hand embolization?
I think the ability to reduce the inflammation is superior in the embolization compared to the PRP or stem cell injection. I believe the mechanism that work in the PRP or stem cell is also the reduction of inflammation, not regenerative, but reduction of inflammation. So I think I know that PRP or stem cell works in some cases, but it's not reliable. It's not reliable.
No, I would agree, and there is no good evidence to support the use of PRP over steroids, for instance, or hyaluronic acid. So theoretically, it's better, but we don't have the clinical evidence yet for that.
And insurance doesn't cover it, so you got to go with
industry is a big thing there for sure.
Yeah. Well, coming up next right here on the Heart of Innovation, we'll get final thoughts from both Dr. Kadar as well as Dr. Okuno. So stay with us right here on KDOW. Don't go away.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAT, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link where circulation and pain left untreated. Your leg might end inflamed.
Welcome back. We just heard some unbelievable information from Dr. Okuno about how easy it is to perform hand osteoarthritis musculoskeletal embolization. Takes about 1 to 2 minutes. It's a 27 gauge needle, in and out. And Dr. Kadar is mind blown. He's interested in exploring it possibly for his own patients. Definitely looking into the evidence, and had really great questions to ask, and what are the next steps in terms of evidence-based approach to hand osteoarthritis and treatment options for the patients. In the break, we got to see more advanced osteoarthritis of Kim's father. Very impressive indeed. And he's heading after the show, I think, already to Dr. Kadar, because he's already too late in the game. According to Dr. Kadar, that's a desert. That's a desert hand. In peripheral vascular disease, we call about desert foot. and that's when there's a really bad vascular disease affecting really the foot and below the ankle. Well, here we have a hand osteoarthritis, desert hand, new term just coined by Dr. Kadar. So we want to learn about how other physicians can learn about the treatment of hand osteoarthritis from a musculoskeletal embolization, what's up and coming from Dr. Kadar, and the more advanced desert hand osteoarthritis with possible joint replacements. So let's start with Dr. Okuno. Maybe you can tell us about how other physicians and how learn. You mentioned you have 150 clinics in Japan performing embolizations, and you mentioned that for just hand osteoarthritis alone, you perform about 5,000 embolizations per year. Is that correct?
Yes. So we are now preparing the international congress that is focused on this technique, not only the finger or some base, but also knee, hip joint, and other frozen shoulder. So that is the meeting. The name Venti, Venti meeting, is held in November this year. November 7th and 8th in Tokyo. That is the first time to we organize, and many physicians will come who are keen, who are interested in this technique. So if you and not only that that situation, but also we are now doing the workshop like to do the ultrasound guided technique. That is the easy one.
And Kadar, Dr. Kadar, are you heading over there to Japan? Are you going to scrub in and work alongside Dr. Okuno so you can come back and treat my dad and me?
Sure. I mean, again, I'm giving talks about innovation. That's my most common talk, innovation in hand osteoarthritis. Certainly, I'll be happy to come to Japan and talk about the orthopedic approach to it and the joint replacement. For sure, it's very interesting. You know, I'm like Misha, I'm like Dr. Ginsburg. I'm a man of evidence. I need to see the evidence. It sounds like it's going to be there very soon. So once it's there, I'm definitely going to be a first adopter.
Well,
in Canada.
I think that you and Misha should be a part of creating the evidence. I think you guys should be a part of the pioneering crew here in Canada and the US.
Is November a good month to visit Japan?
Yes. Early November is still good temperature, and the food is very nice. Yeah.
Okay. The food is really nice. Well, thank you so much, Dr. Okuno, Dr. Kadar, for being here, and great job, Dr. Ginsburg, pinch hitting for Dr. John as our guest co-host. Thanks so much, everyone, for joining us. Make sure you subscribe to our channel, youtube.com/the @ the way to my heart for more great content like this.